Hi, my name is Sharon Wagner, and I titled my poster presentation Breathing Beyond the Tube, High Acuity in Action. For my complex patient that I decided to do my presentation on, she was a 59-year-old female that had a pretty detailed history that included acute kidney injury, metabolic encephalopathy, bipolar, diabetes mellitus, methadone dependence for pain, opioid use disorder, hypertension, schizoaffective disorder, and previous suicide attempts. She did have some allergies, but her primary diagnosis was respiratory failure, and a second and equally important diagnosis was psychological instability. I did decide to go with respiratory failure being the primary diagnosis because it is our main priority to treat while she was in the hospital. She was in there following a suicide attempt, which did lead to her respiratory failure, but the respiratory failure was the priority at hand. Some physical assessment findings were when we got her, she was intubated, but her blood pressure was 106/49, which, as a patient that had hypertension before, this is pretty concerning. Heart rate was 104, temp 100.7, oxygen 95, and then the pain we were unable to assess due to her intubation. But she was pretty agitated, continuously fighting the ventilator, flushed, pale. But all of this had a need for increased sedation medication, which allowed us to be unable to assess many things involving physical assessment. So what they do is titrate a RASS score, and so anything greater than -4, you have some response to stimuli. And at this point, because of her agitation and stuff, she was able to be 0 is having you're calm and alert, and she wasn't calm and alert, so she would still be in the negatives, but she did not have a -4, which would mean no stimuli or response. A chest x-ray was needed just to see the inflammation of her chest, confirm tube placement, different things like that. But then all of her medications were pretty much due to her background and current position. So nebulizers per RT were like albuterol, acetylene, budesonide for respiratory failure. She was on antibiotics because, as you can see in her labs, her white blood cell count continued to increase. And being her risk for infection and being on the ventilator, you can require pneumonia and different things like that. Gabapentin was used to treat nerve pain, and this was previously in her medication list. Two, that could have been caused by diabetes or other muscular issues. Heparin for her immobility and risk for blood clots. Insulin, she's a diabetic, and her insulin was pretty hard to manage while she was on the ventilator. As you can see in her labs, her glucose was 344. When we got that last lab draw, she was requiring a constant insulin drip. Her omeprazole was used also to better handle acid in her stomach and different things like that. Sedation medications include fentanyl, midazolam, and Dex. So like Versed and Precedex and fentanyl are very strong sedation medications. So including all of these was pretty significant in her case. And then lactated ringers as well to keep her hydrated with fluids. So like I mentioned earlier, her number one nursing diagnosis related to her primary diagnosis was the impaired gas exchange related to respiratory effectiveness as evidenced by lab values, vital signs, and need for intubation. Her second was her altered mental status related metabolic conditions as evidenced by suicide attempt. She attempted suicide through method of pills, and this did create a lot of different instabilities in her labs and just different things that could alter her mental status in addition to her other mental diagnoses that she had. Anxiety as well related to other medical conditions as evidenced by physical signs of increased heart rate and fighting the ventilator. No one wants to have a tube stuck down their throat, and knowing that it causes a lot of anxiety, tachypnea at times, so managing her anxiety was also a top priority. For her impaired gas exchange, a short-term goal really was her RAS score to return to greater than -4 because of her increased needs to titrate this higher. It was good to see a goal of getting to -2 where we could still provide her with some stimuli where she could squeeze our fingers and different things like that, not keeping her so sedated. And then a longer term goal would be to return to baseline and not require so much oxygen off the ventilator and different things like that. So an ultimate goal of getting a spontaneous breathing trial. For her altered mental status, she was following a suicide attempt, so short term would be to stabilize her and continuously watch, and just provide suicide precautions in the room, to provide her safety. And then a longer term goal would be to get her vital signs more stable and provide the appropriate interventions for her mental status that could prevent more accidents in the future and implement more permanent safety measures to prevent harm. For her anxiety, the fentanyl was really helping with the boluses to resist the urge to fight the ventilator. We really wanted to control that. And then to meet the realistic outcome of ultimately trying a spontaneous breathing trial and long-term making sure that she was able to identify the anxiety and stressors to return back to baseline to then work with more appropriate resources in managing this anxiety. So some of those interventions were RT, working to get a better grasp on her ventilation, the ABG levels and gas exchange, improve those through labs and different things. You can see her pH was improving. So that was helpful in seeing that was effective. Her metabolic status showed us that she was suffering from different instability, and so just continuing to monitor that and continuing to stay on top of labs to see how the medications and different things were working in stabilizing her condition in this way. And then anxiety, ensuring that what was normal to her, we could keep her comfortable throughout this scary time of being on a ventilator and managing what we could think was pain and different things that provided her discomfort. So long-term, just providing that comfort and hopeful removal of her chest tube and extubation. But a cultural consideration that she did have was her adoption. So family history for her was hard to attain just because we didn't have that. But just keeping this in mind and part of her care, and knowing that there was a huge team in place at the hospital for coordination of care, like RT, physical therapy, trying to get her to be comfortable in bed, repositioning. I mean, the nurses, doctors, residents, everyone was there to ensure her care was top notch and that she just was able to get better throughout the day, knowing that she would have to wean off these heavy sedation medications in order for her to try the spontaneous breathing trial, which would lead us to more of her evaluations and knowing the risks that, these medications do have and the risk of being on a ventilator and immobility for so long. She also could have had a risk for impaired skin integrity. That's a big one with intubated patients just because you are immobile. And so just understanding those different things and working in our best interest to provide relief from some of these things. So, because most of our outcomes were not achievable due to our inability to assess the patient at baseline, she was in need for continuous monitoring to achieve the outcomes that best fit her for the interventions that we had in place. So, ones that we could notice were her outcomes for impaired gas exchange. So she did have a better pH level, which would be due to more of the lab draws and getting the ABG and different things like that. Meaning we're able to regulate her oxygen and carbon dioxide a little better. And then for her RASS score, that was the best thing we could do to see if she could tolerate a spontaneous breathing trial, because when you're -4, obviously you're not responsive, and most of the medications are doing the work. So being able to see her RASS score increase would be the biggest tell of her improved ventilation and stability throughout all of her nursing diagnoses. So, and then I have my references attached, but that is my patient.